I'm
here.
So, yeah, we're just waiting on Nate. But in the meantime, we'll just have a bit of an intro and a bit of a run through the previous presentation that we did. Just as a refresher, I've pulled through some slides that that cover the concepts that we're going to be talking about today. So I'll share my screen, and then we'll get cracking.
Andy, can you hear me, or?
Yes, yeah, I can. Fantastic.
Okay, I'm on.
Excellent. Hi, Nate. How's
Hello.
it going?
Good morning, guys.
Excellent. So, Nate, just to kind of explain, there is a presentation that's got a few slides of the information that we discussed last night. So that'll be on screen as you're kind of talking it through. For everybody who's tuned in, Nate's calling in, so he can't see the presentation, but it's just going to be the information that he's feeding back to you. So the first couple of slides will just run through the concepts, really. So quick refresher on the thought process and the idea of compiling evidence, and then we'll look at 3 case studies from the pro level, and then Porrick wants to have a couple of minutes just chatting about the concept of fitting at the pro level, how it differs from fitting local athletes. So what is critical reasoning? The diagram on the right, I think the 3 circles at the top, analyzing, reasoning, evaluating, they kind of allow you to achieve those circles at the bottom, which is problem solving and decision making. So you're trying to capture data, analyze it, be logical, sort of process it, and try and formulate some plans. So on the left-hand side, some other terms that have been associated with this kind of thinking is conceptualize, analyze, question, and evaluate. And really, that's what we're trying to get across as a message. It's not just the sort of fitting by numbers that some fitters out there, I see this, therefore I do that. We want to move towards processing that information and making a decision based on the evidence. So chain of evidence, that's exactly how we try to assess the information, gather information, and make those decisions based on multiple things, not just one. So our chain of evidence is the interview, before the fit, the physical assessment, and then the on-bike assessment. And if you can see something through all 3 of those phases, then you can be pretty confident that it's something that you need to sort of intervene with. So, if they've told you about knee pain, then there's a restriction in range of motion, or you see some kind of strange movement pattern on the bike, then you're starting to build evidence towards making a decision and deciding what that intervention should be. So hypothesizing, this is the process that we go through with all of our decisions. So you identify what the problem is, and that might be them just coming to you in the first place. It might be it's something in the interview that they're telling you, but the interview also falls into that gathering data section there. So if you data can be things that people tell you, it can be things that you observe, it can be range of motion assessments and core stability, anything like that. It can be marks on pedals or wear marks on cleats and insoles and all those kinds of things. It's all data, it's all information that you pile together to then come up with a hypothesis. Then you test your hypothesis by potentially making an intervention. Does that solve the problem? If it does, then great, you've proven your hypothesis correct. If it doesn't, you have to go back to that hypothesis stage and come up with another idea and test a new hypothesis. So the thing to remember with bike fitting is that we're pretty lucky, really, in the sense that our interventions are rarely permanent. So we can whack an insole in there, we can adjust the cleat position, and then just take it back out again and change the cleat back. So there's little risk in trying something. So this process is really flexible for us as fitters, and I think that's something that we need to embrace a little bit more, and you know, be confident in trying a few things and seeing what works for the client and what doesn't. So trial and error is exactly what we're talking about here. We try something, see if it works. If it doesn't, we remove it and try the next thing. And then reassess and change if necessary. So that's exactly what that no arrow is pointing to on the left-hand side. If it's not right, we go back, we reassess, we form a new hypothesis, and we make a different change. So next up, Nate, if I hand over to you, I don't know why this is coming through as I have to hit the button every time, but so what we've got on screen is the history and previous treatment of pro triathlete 1. So Nate, if you want to give us a bit of background on this athlete. Oh, Nate, are you there? Oh, you're on mute. Hello?
Yeah,
Nate?
yeah. Can you hear me? Okay.
Yeah, I got you. Okay.
So this triathlete came to us, and I say us, it would be Work and I, with some left medial knee pain, chronic IT band issues on his left side, and a little bit of groin discomfort occasionally on that left side as well. He lives in Boulder, Colorado, and has been treated by multiple physios and chiros there, kind of managing the symptoms over the course of the last year, progressively getting worse. And sometimes getting relief from various treatments, but never fully resolving the issues. So that's a bit of the background. Almost all of his issues, again, has been on his left-hand side. That all it for the slide there. Okay. The next would be the physical assessment. So we listen to him. Obviously, we went through a more thorough history than that, asking, if he had any surgeries and fractures, those type of things. But then got into our physical assessment. In a physical assessment, we're looking at, in general, we're going to look at posture analysis. We're going to look at range of motion, which includes joint mobility and muscle flexibility or muscle length. We'll look at strength, and we look at in manual muscle testing, so isolated testing, and then we also look at functional testing. And then we also utilize some special testing, which could include, for example, in the knee, maybe an ACL test, or in his case, he's got medial knee pain. We may check his MCL and the medial collateral ligament stability. So that's an example. So the relevant findings for him after that full assessment, he had some lateral hip weakness. That was bilateral. Bilateral hip weakness, we mean gluteus medius mostly, but that does include minimus and some of the deeper hip external rotators. Left hip flexor weakness compared to the right-hand side. Posture analysis revealed scoliosis, full length of his spine, from C-spine all the way down to the sacrum. The right leg was longer, approximately 5 millimeters, and that was in all positions. So that's supine, hook lying, long sit, and in standing, the right iliac crest was higher. Muscle length testing, tight hamstrings, tight glutes, tight left calf, tight left quad. He also had limited left big toe extension, which is critical for runners, possibly some early onset of arthritis. He had decreased spinal mobility with rotation and extension. And then with the special testing, he had some left hip impingement with some of the special tests. And impingement meaning he had discomfort when we brought him up into hip flexion, internal rotation, adduction, and he reproduced some of the groin pain he was getting. So the groin pain, we feel comfortable that it's related to the hip joint itself. The medial knee pain, he was probably tender at the pes anserine tendons. So medial knee, kind of a little bit lower than the knee joint. For those of you that don't know the pes anserine, that's 3 tendons that attach to one part of your tibia. And we can review your anatomy another time if you're not sure which those tendons are. But so that confirmed that he had some pes anserine tendinopathy maybe there, and so we again felt like that was maybe a correlation to the left hip. So now we're kind of painting the picture of, okay, what do we see from the physical exam, and now how does that relate to what he would look like on the bike?
And I think one of the great things here, Nate, is that we're talking about sort of gathering information, and in a bike fit and that physical assessment that we generally use, which is a much more pared down version than a medical professional would use, how many of these things would we actually pick up? And you know, we might get half of what's there if we're thorough, but your average physical assessment in a bike fit is not going to necessarily pick up some big toe issues, or necessarily be able to sort of fully assess spinal mobility in the way that PTs do. So when issues like this present that are a little bit more complicated and not super straightforward to fix in a bike fit, that's when referring out to medical professionals, and the relationship that we have with Endurance Rehab next door and Nate is so powerful.
Yeah, I think, I mean, it's a big part of this. The critical reasoning is figuring out what's relevant and what's not relevant to the current problem, right? Too, and because we can find a lot of these things, quote, wrong or limiting in a lot of athletes with, you know, so we can line up 100 athletes with no symptoms at all, no issues on the bike, let's say, and yet we find, you know, scoliosis, we find root medius weakness, we can definitely find things wrong with everyone, but what's relevant to the current situation, what's relevant to their complaint and their performance, what's impacting their performance. And so that's definitely where the critical reason. You're gonna find plenty wrong, but what's really relevant to the problem. So that kind of would come into more our interventions. What's our solutions? And so for this person, looking at that, his left hip and how restricted that left hip mobility was, his symptoms there, and also conferring with Porrick, of course, what he look like on the bike. On the bike, he was more rotated forward in the transverse plane, left side being rotated forward. So he was in relative hip internal rotation, adduction, flexion, of course, at the top of the pedal stroke, excessive flexion. So creating that, and then his tibia was externally rotating on that side. So you had the opposite rotation, the femur rotating internally, tibia rotating externally, which is, you know, as we know with runners in particular, but also in cyclists, that can be a red flag for pes anserine issues. So we knew that. We also knew that could also be a cause or a symptom of hip impingement. So knowing that, I knew some of that going into it from talking to Porrick before I looked at him. So we discussed shorter cranks as a solution. He was not interested in that. He was he wanted to utilize physical therapy to get this better, and wasn't interested. So of course he's tried a lot of stuff in the past, not successful, and we were giving him some new things to try, but suggested that, you know, this is probably going to continue if he doesn't use shorter cranks. So in the end, we were I was able to convince him to get an X-ray just to see, because there's basically two types of impingement in the hip joint. You can have a soft tissue impingement, or you can have a bony impingement. And then bony impingement, there's various types of that as well. Not going into all the detail with that, but if it's bony, obviously that's we can't change that. If it's soft tissue, we could change it. So that is a major factor in what we can recommend regarding bike fit and crank length. So, and are they going to get better with the therapy exercises?
Nate, can I chime in a little bit here?
Sure.
So what was fascinating about this to me from a biomechanics standpoint is that this also involved significant engineering input. So we had an aerodynamicist, myself, Nate. We even involved an exercise physiologist in some of the later analysis of this individual. And in our first wind tunnel session, we saw that the shorter crank was significant in terms of both saddle pressure. So we saw it was significantly more stable. But in addition to it being more stable, we also saw slightly lower drag. Now, it wasn't madly significant lower drag, but, and I think maybe Nate, this is something I'd like you to talk about is, you know, Nate and I deal with a lot of psychology when we deal with Pro Tour and when we deal with elite triathletes. And in this case, this athlete had significant bias towards longer cranks. It was almost like a sacred cow for him. So even in the face of pain, hip restriction, restricted range of motion in the cycling specific position, significantly better stability and lower drag, we were still sending that athlete in our first round, because this was a multi-year deal. And I don't know whether you remember this, Nate, is that the crank length didn't change for a season. And we ended up having to have more pain and more diagnostic imaging before we actually changed to the suggested crank during one of our initial analyses that proved to be aerodynamically better, slightly better stability. But the feeling of the athlete when they rode outside was, oh my God, the world's ending. This is 5 mils too short. I just want to
no, that's yeah, no, thanks, Porrick, and that's right. And yeah, I mean, this case I thought was interesting, mainly because, like what you mentioned, the psychological piece of it. It was from an exam and bike fit. Once we saw him, I thought it was pretty cut and dry and more like a home run type case. So we're going to get this guy better. I shouldn't say easy to figure out, but it was not as complicated as a couple of the other cases we're going to talk about. So I knew once we saw that pretty dramatic hip limitation and impingement that we're going to get this guy feeling better. But we got to know if it's bony or not bony. And for us, we would normally not order the X-ray. We would just move forward. Let's try some exercises for a while, see how you do, and you don't improve. Let's get the shorter cranks and move forward. But because he was so resistant, we felt like he needed to actually see it and to believe it. And if it is there, he's got to see it, and that will help him. And it absolutely did. Once he saw the X-rays, he changed his mind immediately. And so that was a pretty powerful exercise to go through, much like you guys using video or pressure to show your athletes the difference it makes. Sometimes they maybe can't feel it, or they have a mindset where that's new, that's changed, I don't like that doesn't look cool, that's not how it always is. And so that helped us educate him. That was a very powerful picture for him. So we did shorten his cranks, Porrick did, and he did maintain doing some of his physio stuff. His knee and hip issues were gone. I mean, it was pretty dramatic. The difference, something he'd been struggling with for a few years, they were gone almost immediately.
Yeah, and I think one of the sort of take-home messages here is that sometimes clients struggle to associate knee pain with an issue at the hip. So, you know, other people in the past have talked about kind of, Curtis does a presentation where he talks about the, you know, the villain and the victim, and it's not always the same. But in an athlete's mind, their knee hurts. They always think that it's a knee-related problem, and so convincing them that actually it's related to the hip, and this change that is going to help with the hip is then going to help with the knee. Sometimes that's a bit of a struggle.
Yeah, that's for sure. Absolutely.
So,
and you know, one final thing I'd like to just say on this is that, you know, this athlete went on to have life-changing and financially life-changing performances afterwards. So it's not, you can have a pretty profound effect. And from a training perspective, you know, there were some differences and some changes in how they conducting themselves as an athlete, but the biggest change was, you know, the lack of pain and what that did for the ability to do training volume and everything else. So it's even when you instinctively know what the right thing is, even when you've gone through a critical reasoning process, sometimes it really, you have to bring out bigger evidence guns. And it's a recurring theme working with professional athletes is, on the one hand, we think that, oh, this person is going to be super open to the information, but they have more sacred cows in terms of what works for them than normal athletes. So we try to practice a very evidence-based approach. So Nate and I will do tests or we'll illustrate biomechanical concepts to athletes, but a lot of the time we're not doing it for ourselves. We're doing it 100% for them. Sometimes we'll even do tests, or we'll do, you know, we'll look at angles that it's crystal clear what's going on, but it's not really about that. It's about the athlete seeing us go through a process whereby we're trying to figure out what's going on. Even if it's evident to Nate or I in the first 5 seconds what's going on, there's almost a showmanship component of this where the athlete has to see that you're going through this reasoned process to show them what's going on. And that's why a lot of the tests Nate does and a lot of biomechanical analyses we do are very visually oriented and very queued up so the athlete can see what's happening, because that psychological component of what's happening is absolutely critical to compliance and to ultimately them not taking out the Allen key after their first ride and changing it back. Nate, do you have any further comment on that?
No.
Okay, so let's move on to the second case study. This time it's a pro roadie. This one's pretty in-depth, pretty complicated. So I'm just gonna put everything on the screen and then we'll talk through it as we go. Actually, let's go to there. So Nate, if you want to take over.
Sure. Yeah, this, you know, we started off with an easier one that made me feel really good about my knowledge and helping athletes, and then now we go to one that's a super challenging and ongoing and humbling. So so this is an athlete that that I saw in October 2018. I was asked to see them kind of last minute, and so it was not a regular appointment. It was very quick. There was no table available, and I didn't take a lot of notes with it. So you know, my bad that I'm not going to be able to give you tons of notes, but I'll give you the gist of our first meeting, and then obviously I have more information ongoing. So I was asked to see this athlete because of low back pain, and was recently diagnosed with disc degeneration, which is losing the disc space and losing the cushion in between your vertebrae. And this person didn't feel like they were sitting straight on their saddle. So so the quick evaluation was that there was limited spinal mobility, flexion, extension, actually some pain with extension, and limited rotation left and right, pretty significant. So extension and rotation limitations were 50% reduction with flexion being about 25% reduction, which is not something you would typically see in a pro cyclist. So pretty atypical. Core weakness, glute weakness, and then in some nerve gliding restriction. So I gave her this athlete some core exercises, some mobility work to do, knowing that in 6 weeks we were going to meet again, and I was going to be able to do a more thorough assessment at a camp, at the next camp. So let's get started on some stuff. Let's see how you look in December. So in the December camp, she came back and reported not having any pain on the bike anymore, mostly stiffness, about approximately feeling 25% better than she was before. But she was still feeling like her left leg wasn't working as well. She was concerned about, having that. For those of you who maybe don't know, external iliac artery fibrosis, which is like a kink in the artery in your hip. She was concerned that maybe that side was an issue. Still not convinced that it was all from her back. So there was a number of things still happening, and still not feeling straight on the saddle, like she was able to sit straight on the saddle. So able to do a little bit more of a physical assessment with her this time. Noted that her left side of her pelvis was elevated and rotated forward in the transverse plane, but also in the sagittal plane. Her core was much better when we tested her, but still relatively weak compared to normals for pros. She had some mild hip impingement, tight left hamstring, weak left hip flexor, some medial glute weakness, and her spinal mobility was still significantly restricted. Even though it was improved, the left side was dramatically different than the right. One thing that I'll note that on her X-ray and subsequent CT scans, they did note that she had sacralization of L5 on the left side, which means that normally you have space at each vertebrae in between the joints on each side, and you have a left facet joint, right facet joint at each vertebrae going up and down that allows movement. On the very lower portion, L5, S1, the left side was fused or close to being fused, and that is in a young person, that's congenital, meaning that's the way they were born. Can happen as you get older as well. That can confuse, but typically you see that in someone in there that's 60 plus. So that means that left side, that would explain some of the left side maybe not moving as well as the right hand side. So for us, we have to think about, well, what is maximal to get out of that side? Is she at the max, or is there room for, instead of being restricted by 5 centimeters relative to the other side, could she get to 3 or 4? Is there room for improvement? There's not any way to really know the prognosis of that without working on it. So what we did with her was we worked on it. She did exercises for that, and we tried to get her pelvis really hyper focused on getting her pelvis to sit more stable and evenly on the saddle, and that was the goal of the exercises. So really addressing the asymmetry we saw in pelvic rotation, pelvic and lumbar rotation. So that was the primary thing. So we really worked hard on left crossovers and 90-90s, right side scorpions, which is the opposite pelvic rotation, tried to shore up the difference in left hamstring mobility. And we did suggest, again, shorter cranks, higher bars. She never did go to the shorter cranks at that time. She eventually, later that year, I believe it was in July, she did raise her bars and noticed a difference in how her left side felt, meaning left leg feeling stronger on the bike, particularly in the road position and the TT position. She was still struggling in July still. The challenge for us is that, you know, we give a program, teach them how to do it, and then we don't see them again for a year, basically. And so it's a lot of communication via WhatsApp and back and forth. But as you guys know, it's tough to really test your hypothesis and do critical reasoning without physically seeing the person on the bike, off the bike. And so that kind of delays things a bit. You can't. It was great for us. I felt like there was a win for us to get some improvement, considering her diagnosis and considering we don't have a lot of time with her. She did also have, throughout that season, as the season went on, get some saddle sore issues that was going to require surgery. So she did have surgery later in 2019. But that was scheduled. But then prior to that, she had a crash, September 2019. Fractured her pelvis on the right side, fractured the humerus on the right. It was a proximal humeral fracture. And so with that, she had six weeks of non-weight bearing, not able to walk, had to use crutches. So obviously in that instance, we see a dramatic amount of muscle atrophy in the hip, in the whole right side. In the shoulder, we'd also see a significant amount of atrophy after a humeral fracture. It was never clear if she also maybe had other soft tissue damage. They did not do like an MRI or CT of her shoulder. So we just worked with her with what we had, of course. But so this created a new and more complex issue. Someone who we were trying to fix, and we had plans to go, okay, we're going to really spend a lot of time in October and December camps on fixing this rotation, on the cause of why she got the saddle sore, and really work hard on that. But now we're dealing with someone who comes in October and can't do anything, can't even ride the bike. So we're starting with, we have different goals now, and so now we examined her in October, and she was in the healing phase. It was, roughly, maybe 6 weeks out. So her shoulder was very weak. Her shoulder muscles, scapular muscles were very weak. Range of motion was limited, which was all that is a concern because that's one of our contact points. And so if she's not able to apply a lot of pressure through that side, not be able to support herself and likely shift her weight towards the left, which she was already doing prior to this accident. And so she would also then had some more discomfort in her low back, discomfort in her right hip. She didn't have any more left low back pain, but mostly everything was on the right-hand side. So at that point, evaluating her was evaluating someone who, after fractures and healing and following the normal healing process and giving it time and more education to her about getting her back to square one. And so it's a lot of range of motion, a lot of strength work to try to overcome some of the issues that she's going to have from basically just these fractures. And then hopefully, the goal was to get her more stable. The hope was then by December camp that we could do more with her. But with this athlete, like a lot of our athletes, again, we have a psychological piece to this. This is someone who out of all the professional athletes we work with, is in the top 1% of the professional athletes we work with regards to OCD-ness about getting on the bike. It was extremely hard to not allow this person to get on the bike, to want to push, knowing it's also an Olympic year at that time. There was a hyper focus in going way too fast to get better. So there was a lot of communication on how to rehab this properly. And we weren't discussing really a lot of the old issues at that point. She was unable, one thing of note, she was unable in October to do even just a push-up on a table, meaning, you have your plinth set up and you do your hands are on the plinth, your feet are on the ground. So it's a really modified push-up. Could not even go halfway down. So that tells us she's not able to be stable on the bike. She can't even do that, right? So that's very simple. So the goal, we had very simple goals for her for December. We want you to be able to do these push-ups. We want you to be able to test your core to test better, your hip strength to test better, your mobility to improve. And let's look at all that stuff. So she came to camp and, as per normal, worked very hard to get a lot of those things better, and did. So core strength was improved, hamstring flexibility was equal, hip motion was normal. The shoulder range of motion was improved, but still restricted, and still pretty weak. She was able to do a modified push-up, but not a normal push-up at that point. She was a bit more lax on the shoulder exercises than with the other stuff, hypervigilant about the lower extremity stuff, not as much about the shoulder. So there was a lot of scolding with regards to the shoulder which she took well. Notably the left spinal rotation had not improved and had been about the same as it was pre-crash. She was riding again and not feeling any pain, although did not feel comfortable and did not feel straight, felt much worse when it comes to how shifted she was on the bike. And that's what we saw when we had her on the trainer, is that she was significantly more shifted on the bike, which we go into interventions that it required a lot of work from Porrick, engineers, and I every day, having her on the trainer, looking at her every day, trying different interventions, a lot of trial and error, which Andy mentioned earlier. Is there was a lot of trial and error trying to get this person as comfortable and straight on the saddle as we could, so that she could do the training she wanted to do. And so those days look like this, is that I would see her before getting on the bike. So I would see her first. I would do some soft tissue work, some joint mobility work. And then she would go get on the trainer, and we would take a look at her. She'd spin on the trainer. We'd see where she was. We'd discuss other interventions. And then she would go out and do the group ride. It started off more in the beginning of camp where she was not doing the group rides, and she was just doing trainer rides. Then it started with rides on her own, and then it progressed to where she was able to ride with the group. So over the course of about 10 days, we saw dramatic improvement in her mobility, how she felt on the saddle, and her ability to pedal more normal and put more power down on her rides. But that was a very aggressive approach that for us to take. We typically don't, like I mentioned before, we typically don't get a lot of time with the athletes. And at this camp, we were able to get a lot of time with this athlete and make a pretty significant change in a short period of time, for a period of time being 10 days. That's extremely short for us, for someone who's had chronic conditions like this. So to this date, more recent conversations with this athlete still doing really well. Training is not inhibited at all. There's no issues with her training. She's not perfect, and on the bike, that was never going to be our goal to make this person perfect. We have to be realistic.
Can I chime in a little bit on that, Nate?
Yeah.
So this was fascinating to me because for a number of reasons from a pure fit perspective. So like Nate was saying, we were almost changing strategies on a daily basis. And some of those strategies were focused on simple things like we actually put a pull tab on the back of the saddle to facilitate centering. So we were giving the athlete visual references with a piece of tape on the back of the saddle to help them center their center of their spine, or the literally almost, if you think about the cheeks of their glutes, they were trying to center themselves. And one of the interesting things for me is that sometimes athletes will get feedback, because this athlete we'd obviously worked with for quite a while beforehand, before there were any symptoms. So there was already an emphasis on centering. There was already an emphasis on the gross things we could see as fitters. But until pain came into the mix, and until pain started to escalate, Nate and I had a lesser role in working with the athlete. Then the degree of compliance the athlete had dramatically changed. So now the groin discomfort and some of the other issues were something that was now linked partially to posture, as well as all the underlying pathologies. Now, by the time we got to this final camp in December, where we were starting to ride, also the training staff were working with us. So we had, instead of going out and doing massive miles, this athlete was now starting to do massive amounts of superstructured intervals. And the interesting thing about doing intervals on a trainer is it does provide that opportunity to focus on posture. So Nate and I would be working on postural elements. There were visual cues with the saddle. We even had pieces of felt and stuff glued to the saddle to help give visual clues that was the posture better. So even though there was range of motion issues, there were other challenges, what we ended up with, this athlete actually sat on a saddle better than they did at the very beginning of the process. And the catalyst to that happening was getting hurt. So we ended up with superior symmetry, better center of pressure movements, more symmetric relationship with the saddle. It actually caused us to learn a lot about saddles and to some degree female anatomy and accommodating these kind of things. And then the training staff were also modifying the training. And when this athlete got back on the road, despite all the rehab, despite all the time off the bike, CP20, 1 hour power, all of those things were the same or slightly better than the year before. So sometimes through adversity and through these things becoming issues, you actually end up in a place that you never intended to be, but there isn't necessarily a one-to-one correlation between adversity and then you end up massively compromised. And this was probably, of all the clients we've dealt with at a pro tour level, this was one of the most intense amounts of effort and energy, not just from a biomechanics standpoint, but there was a lot of postural, there was a lot of body cueing, there was a lot of other things that went into this becoming a successful solution. And it was trainer, it was Nate, it was some of the other soft tissue people, and then it was sometimes managing the stuff we knew wasn't true. So there's a lot of mythology in professional cycling, and there's a lot of, oh, we'll do this, and sometimes that's Nate and and the biomechanics and engineering team saying, well, I understand you feel that way, however, there isn't really data to support that that's true. So there were a lot of elements in this, and there's a lot of psychology to what we do with world-class athletes. And when somebody's already got amazing palmares, it can be sometimes quite difficult to get them to where they need to be. And sometimes these injuries become a motivator. Nate?
No, that's great. And I think my final word would be, that was definitely a team effort. None of us could have done it by ourselves. It took the team to get this athlete where we needed to go, and it took a lot of work. And so we didn't have the answer straight out of the gate. like the first case we talked about, I felt real confident. I had the answer, straight out of the gate. It was an easier solution for me. This person wasn't, and it took time, and it took a lot of collaboration. And so luckily, if you're working with local athletes at home, you can ask them to come in more frequent. And you do need to have your team, surround yourself with a good team that doesn't have egos and that you can collaborate really well with. And that was the key with this one.
Yeah, I think the old phrase "pain is a great motivator" can sometimes be a positive.
Yeah.
Okay, so third and final case study. This is another pro roadie. So we'll get the history up there first of all. Nate, if you want to talk us through some of the things there.
Yeah. This athlete I saw December 2015, and had a history of fractured clavicle surgically repaired a couple years prior to that. Also had a history of fractured lumbar vertebrae. But the primary complaint at this time was a little bit of weakness in the arm, but more was that that they didn't feel like the hoods were positioned correctly on the bike. And word got back to us that this athlete kept yelling at the mechanic because it felt like the mechanic was messing with them and moving one hood on the right side, like out a little bit farther away, like a couple millimeters away. And constantly, this athlete was constantly yelling, "You don't have the hoods in the correct spot. I know it." And they were showing us like they're right. But the athlete didn't feel that way, and then was also complaining of shifting a lot on the saddle, particularly to the left-hand side. So there was this two major things, that the shift in the pelvis to the left side, but also not feeling right or stable on the right hand contact point. So
Can I just chime in one piece of
yeah,
data there?
anytime, yeah.
So the other thing that we were seeing working with the athlete, it was this obsession with the right cleat, that it wasn't straight, or that the foot wasn't doing what they expected it to do. So there was this series of protracted discussions about, let's do this with my cleat because I want my knees and my feet to look the same. And it took a lot of effort with pressure mapping and in-shoe pressure mapping and Nate to try, and I'm not going to ruin the rest of the history by telling you what we discovered, but this was working with fitters, working with mechanics, talking to Nate, talking to other soft tissue people. And this was a highly frustrated, world-class, very famous athlete that Nate and I you never get nervous working with an athlete, it's your job, but we're very cognizant of who this was and how we had to A, be right, and B, not just placate the athlete, because one thing that Nate and I both abhor is this bike fitting appeasement syndrome. So if you just do what the client feels that they need without having a critical reasoning process, all you're doing is you're basically just giving the athlete what they feel they need. Whereas, as we know, the body will give you bad cues, bad information, and lead you down the wrong path sometimes. So at the one time, in the one sense, their feedback is super important, but then in the other sense, you have to weigh it critically and evaluate, well, is this cleat issue a cleat issue, or is it something else?
Yeah, and you had and I think, if I remember right, you were able to look at this athlete the year prior, and it was a different physio at that time, right?
Correct.
Well?
Yes.
And so this problem, hadn't been resolved, I guess, right? And
Correct.
And so we knew that this was a problem before this athlete fractured lumbar vertebrae. This was already happening before that. So that was an important piece of the history as well. So in the assessment, you know, typically it's not. I don't think it's common to start looking at maybe the upper body or the shoulder or C-spine, but obviously we do it with all of the athletes, but we pay particular attention when they've had some history of clavicle fracture, and most of them have. If they're pros, most of them have a history of it, unfortunately. So there was some right arm weakness. Right scapula was, from a posture analysis, was abducted and winging. The right tricep was weak, significantly weak. C5, 6, C6, 7, those two places in the cervical spine, that those facet joints were hypomobile, meaning they don't move as well. The right scapula muscles were weak. Lumbar rotation was restricted to the right compared to the left. Thoracic rotation was restricted to the left relative to the right. Getting this corkscrew type motion, which we see in scoliosis, but we also see as an adaptive pattern. So we kind of red flag that as well. Some medial glute tightness. The pelvis was rotated anteriorly on the right-hand side. Right leg was 5 millimeters longer, approximately in all positions. And in the left hip Faber test was restricted by 5 centimeters relative to the other side. And so those are kind of the key findings that we saw. And knowing that, having the luxury of knowing that this problem was ongoing, and a previous physio had worked with them and had tried different things, and so I'm, you know, I look at all the data that I get from the assessment, and what are potential causes, what are potential effects. So what things are more critical as solutions to the problem, what things are there but maybe not going to be solution driven. In other words, yes, the glute med was weak, and we have this restriction in lumbar rotation. So, okay, we could work on those things. Would that solve the problem? That's possible, and that could be one route that you go. But going up the chain further and seeing that remembering there's a history of this clavicle fracture, and then seeing that the scapula was abducted and winging, that there's severe tricep weakness and some decrease in joint mobility in the C-spine, those are greater red flags for me. Those were the right tricep weakness in particular. That's not normal, and that can be related to a nerve compression. And knowing that's a greater red flag. And so, okay, could that be a cause of pelvic rotation on the bike? Could that be causing this rotation that's happening, and this feeling of the hoods in different positions and the cleats? And discussing everything with Porrick as well, you know, it makes sense. If you're weaker in your upper body on that side, you would maybe bring that hand back away from the hood to stabilize yourself, or bring your hand in a little further on the handlebars, just to stabilize yourself better, particularly if you're racing a longer race where you might get fatigued, or if you're racing on cobbles, you may do that. So when you do that, obviously when you change one contact point, like you guys have talked about before, it changes all the other contact points. So again, having that history of that, we focused on this upper extremity issue as a driving source, as a potential cause, because I'm say potential because I don't know it as a fact. Potential cause where the other findings, like the lumbar and thoracic rotations, as effects, as things that are happening because of this this real cause of the problem. So our goal was to try some cervical joint mobilizations to treat the hypomobility at the C-spine, do some nerve gliding of the radial nerve that supplies the tricep, some tricep isolated and functional strengthening, scapular strengthening, and then talk to Porrick about what solutions could we have to make him more stable. Is it narrowing the bars? Is it reducing the reach for the right arm? Use the tops more than the drops or the hoods? What solutions can we do? In addition to that, there was, because the tricep weakness was so severe, and this was my first camp with the team, I of course wanted to have a discussion with the team physicians, which I did, and discuss this, what I felt was nerve weakness, and where could the cause be coming from. So the only way to really understand maybe where the cause could be coming from versus from we're trying to decide, is it coming from the clavicle injury this athlete had, and where you could injure the brachial plexus, where the nerves run right underneath the clavicle, or could it be coming from the cervical spine? And we could help tease that out by doing a needle EMG or nerve conduction test. It's not something that we do. That's collaboration with the physicians, and they'd have to be willing to order that. At that time, they didn't feel they wanted to do that. They wanted to give the physio a chance to see if physio and bike fit changes would make a difference for this athlete.
So once we started to discover what was going on, and once the athlete started to realize that, okay, you know, I am going to have to think a little bit more about what my cleat alignment is like, and think a little bit more about how some of these issues are starting to affect you. Now I was in the team vehicle following them, and the athlete would come back to the car and ask me, is their posture right? And ask me, because we also talked about some different ways of trying to recruit and engage. So now we have more knowledge that it's some upper body, there's some weakness, there's some nerve issues. And now the athlete is finally going, well, okay, I don't really need my cleat tweaked. I need to understand that I have some weakness or some inability to fire at the top of the pedal stroke, and that affects the position of my knee, which makes my foot look asymmetric, which means that you know, I'm struggling with where my cleat is. So they would be coming back to me, and this is surreal because, you know, I'm this bike fitter from Ireland who gets to do all these amazing things, and this is, you know, amazing. But part of the reason that we were able to get to that point, that there was enough trust to reason through these things, is because of, you know, a chain of evidence. So some of it was fit, some of it was pressure mapping, some of it was force analysis in the shoe, some of it was footbed, some of it was NATE, some of it was, you know, understanding these nerve issues. But again, this was a super multifaceted approach, including team directors, including because, you know, this person was very kinesthetically aware, so they would want whoever's in the team car to be able to say, am I doing it or not doing it? And, you know, so this was, again, one of these big collaborations, and there was a large postural and proprioceptive component to helping this athlete understand why they were battling with perceived contact point issues, when of course it was the way their body was interacting with the contact points. And you know, how do we accurately communicate that and have a multidisciplined approach to fix it? Right.
I just finished this one up. That in the end, arm strength did improve, and like you were just saying, all the biofeedback that we gave the athlete and all the stuff that you and the directors and coaches did with them resulted in a positive result. So a positive result meaning sitting more square and feeling more comfortable, and most importantly, understanding, like you kind of mentioned, just having that understanding of why was huge, because it was not for lack of work or lack of effort on the athlete's point. It was understanding, and I think it was, you know, I hate to say that this was a missed thing. It wasn't missed. It was just that it's a reminder that we have to look at all the contact points because and review your assessment, because you could easily go, well, that favor that was restricted, let's work on that. Let's work on the trunk rotation limitations. Let's work on the hip weakness. And you could, those are limitations, but then that wouldn't result in the end solution to the problem. And so you have to do a thorough assessment, but understand when looking at that, how do all these limitations affect the contact points, and where can I make the biggest change, and start there, and that's a starting point, and that's based on your hypothesis, right? And that's your best guess, and that's going to change and evolve with athletes for sure.
Yeah. So, thanks very much, Nate. I think that's been a really useful insight into the process of fitting, especially at the pro level. And I think there's a lot here that you can implement at the level that most of us work at with local club athletes. It just requires that multidisciplinary approach that teams have access to. So, if there's anything that you take from these webinars that we've been running, it's that having people around you to refer out when you reach the limit of what your interventions can do, it is incredibly powerful and will give that client more potential solutions to their issues. And if you're honest with them and you say, a bike fit's not going to solve this and we need to refer you out to a medical professional, if the medical professional then resolves the issue, you still are seen as this problem solver in the eyes of the client because you were the one that referred them to that person. So, you don't need to be the one that solves every issue, but you need to know the person that has the best chance of solving that issue and pass it on in that instance, because your reputation as a fitter will improve exponentially if you can pull all this together and get people on your side working as a team to solve these problems.
And I just wanted to also draw back to kind of the genesis of how Nate and I ended up in a situation to work with these athletes. This was, I just relocated to the US, it's early 2000, Nate's coming in saying, hey, there's all this other stuff going on that you need to pay attention to. I'm a frustrated bike fitter going, why the hell is this knee doing this? And how do I do orthotics? And I don't like the orthotics that this, individual supplies for my athletes. They don't fit in shoes. I've got to grind them. I have all these problems. And then Nate comes in and we realized pretty quickly that, there's something in medical fitting. So Nate and I schedule half a day a week, once a month, and he comes in and we do a medical fit. So I get all of Nate's insights. Now, what that does for me as a bike fitter is like, oh, hang on a second, I'm not looking at this right. I don't understand all these factors. And then it went to every week we did a medical fit together. And then it went to sometimes 2 medical fits a week. So we started to pretty quickly get to the point where my body of knowledge and my ability to gather evidence improved. So it helped me grow tremendously as a fitter, to the point that when the building beside Nate's came available, I can walk through double doors in our building into work with PTs every day. And Andy and I have that resource side by side with us. So if I see something strange, sometimes that person is already a client of Nate's or one of Nate's locations. So we have this interchange back and forward that we're able to move information quickly. And then not all PTs, not all interventions, not all levels of knowledge are the same. So, we had in that last case study, a PT who had a lot of cycling experience, was working with the athlete unsuccessfully. So once I started to work with Trek and Trek-Segafredo, it became very stressful for me not to have the Nate resource. I mean, I had no go-to that I know that I can work with, and I have a nomenclature and a way of working with. Nate and I had already worked together for 14 or 15 years before we started working with Trek-Segafredo. So it's really important to have the rapport. It's really important to have this person as part of your ecosystem of resources. And it's very important that you build that way of working with them. And sometimes that involves going to their practice and doing evals with them, or having a client that you know needs help, but you don't know what the heck is wrong, because there's a limit to where your skill set begins and ends as a bike fitter. Attending the PT session with that athlete can, you know, open your horizons to understand what's going on. It doesn't endow you with the mad skill of being able to say, I've just bypassed 7 years of education and now I can diagnose a structural leg length discrepancy or some other thing that is going to impact what you do in a bike fit. But it does allow you to upgrade what you do to a huge other level. So when Nate came and started working with me at the Pro Tour level, and Nate and I have been all over Europe working with these athletes now, it upgraded everything that I do and got to learn a whole different level of things. Because the other thing with these Pro Tour athletes is they come to the table at a much higher level. So if we think about the MOC, or medicine of cycling protocol, you know, there are two types of bike fit. You have optimal and you have accommodated. 99% of what we deal with in a bike fit is a person who's relatively compliant or completely non-compliant. So we're going to accommodate who they are. When you're dealing with somebody who tells you, I will turn myself inside out and back to front to get stronger than I was before I broke this, injured that, and come back and they are stronger, there's no accommodating, or there's accommodating for a period of time while they move back to optimal. Nate and I have been greatly honored to be a part of that process of, I just had rods put into my spine, I have nerve damage, I have this, I have that, and you get them back to optimal again. And that's a completely different thing. The one last thing I'd like to say is that evidence is way more important for these Pro Tour athletes. You can't just say your saddle height's too high. You can't just say, well, I don't think this is right, or that's right, or this is wrong, or that's wrong. So all of the setups that we do when Nate and I work with these athletes, they're all where we're trying to give them numbers or data. So Nate will do a Y test with them, or he'll do something to score them. Same thing with, we'll have high-speed video, we'll have pressure mapping, we'll have aero sensors, we'll have all sorts of feedback tools for the athletes, because your knowledge is not immediately just deified where they go, okay, bike fitter says this, I'm going to do it. They need to see the why, understand the why. And it's way more powerful when Nate finds something, I find something, and those two chains of reasoning get connected. And then I have a much better chance, and Nate has a much better chance when we work together to get the kind of outcome we want. And world-class performance outcomes are generally multifaceted in terms of how we get to that point. Nate, do you have any kind of closing comments on that?
No, I mean, I would just say, you know, we meaning physical therapists, need fitters as much as you guys need us. I mean, that street goes both ways. So I think our expertise are really symbiotic and work so well together. And I know if you don't have a PT you work with, I'm sure you can find one that would love working with you. And in general, they love being problem solvers, just like you guys. So it's been a tremendous collaboration for us, and we keep evolving every year. Even after doing this 20 years, you know, we still are evolving and getting better. So it's a fun ride. So I highly recommend you guys find someone you can work with.
Fantastic. Thanks very much, Nate and Porrick. Just a quick run through some stuff that we've got coming up. On Monday, we've got another webinar on Pales Rails, and hopefully that's a tool that you can use to, again, shift from sort of accommodated to optimal, help improve range of motion, that kind of thing. Then the following Friday, we've got another free webinar on the cyclologic process. So we're going to run through kind of what our average fit looks like, a couple of the different services that we have, what fit studios we have here, and what services we can offer, just to give you a sort of snapshot into maybe some additional services that you hadn't thought of, or maybe some additional tools that can open up another area for you. Ongoing, we do offer one-on-one webinars. If you're interested, then get in touch, and that can cover any topic, and it's a time that will suit you. My email address is there at the bottom. If anybody has any questions on the webinar today, then do feel free to ask them in the little chat box. I don't think we've had any through the course of the last hour, so obviously we've been either very thorough or we've switched you all off.
Yeah, sorry if I put you all to sleep.
No, I think it's been very thorough, and we've covered everything that we could have covered, hopefully. So, but yeah, if there are any questions, then do shout up. It doesn't look like there are, so if you think of any in the future, my email address is there. Feel free to fire them through. I'll pass them on to Nate or Porrick if they're related to points that they've made. And yeah, hopefully you'll join us on Monday and next Friday and continue to support this webinar series. Thank you very much for joining us today.
One final thing, if you like any of the topics we've covered in the past, we have videos of all those webinars, and you can email Andy for options to access those. So if you want to see critical reasoning 1, or you want to see some of the other stuff we've done on foot anatomy or some of the other webinars, that content is available, and Andy can help you with that.
Yeah, fantastic. Good point. Okay, well, thanks for joining us, and yeah, we'll hopefully see you all again soon. Thanks very much. Goodbye.
Thanks, guys.
Bye.